Okay, so I figured since a couple of you asked about chest tubes and I have some downtime on my Sunday with my 6 patients, I would go through this lecture with you guys in a social distancing friendly way. So I think it'd be most helpful if you open the PowerPoint and I'll guide you on which slide we're on. We'll kind of talk through it together. Side note, I used to do thoracic surgery before coming here, so I have a decent exposure to chest tubes. I'm not an expert, but pretty familiar with the maintenance of them. All right, so we're on slide 1, the title slide right now. Now we're going to slide 2. Okay, so pleural, pulmonary anatomy, physiology, pathophysiology. Just remember that there's the visceral pleura and the parietal pleura. The visceral pleura covers the surface of the lung. The parietal pleura covers the inside of the chest cavity. And in an ideal state, in a normal state, there's they basically are like this. They're completely together side by side. And that is due to the negative pressure within this space, which is called the intrapleural space. So there's always like a vacuum environment in there, so whenever you breathe, the lung expands and the chest wall expands and goes down because they stay together the entire time. When that pleural space is disrupted by a pneumothorax, then that creates that potential space where now the lung is starting to collapse. So again, I'm kind of like going off rogue here. Right, the negative pressure keeps the lung expanded. There's normally about 50 cc's of fluid in that space, and then if that negative pressure is not maintained, the lung can collapse. We're going to slide 3. So the use of the chest tube is to reduce the positive pressure in the pleural cavity. If for any reason that space collects air or fluid, it starts to become less and less negative and you can't achieve that vacuum anymore. So you can see on that picture, the chest tube is within that pleural space where the blood is. So the purpose is to drain the blood out, resume that negative pressure and that vacuum, that pleural-pleural opposition. We really want to promote lung re-expansion because as soon as you get that visceral pleura and parietal pleura together, it fuses and then it keeps the lung, together with the parietal pleura as you breathe. Next slide. Okay, so chest tube overview. I actually have some chest tubes here. These are really small, but so in the OR after thoracic surgery is performed, you can kind of see these little drainage holes on the end there. So the surgeon would have just done his thoracotomy, and he inserts this tube in the hole. So when you go to see the patient, you're seeing this end of the chest tube outside of the body, and the proximal end with these drainage eyelets need to be underneath the skin level. If for any reason the nurse calls you up there and they're like, something's wrong with this chest tube, there's like a massive air leak, it keeps bubbling, one thing you can do is make sure that those drainage holes, you can't see them outside the skin surface. So yeah, it'll be basically this is what you'll see, and I'll show you the connector piece to the Pleurovac as well. Okay, so if this is in and you get a chest x-ray, you're basically seeing, this piece that's internal in the pleural space against the lung, and this is out connected to the drainage box, which is called a Pleurovac. Okay, when 2 tubes are inserted, one will be placed apically, like I was just showing you, because the air rises. So this is to drain any pneumothorax, which tends to be apical. And then one would be placed basilar to drain any fluid. I feel like most commonly patients here only have 1 chest tube, but if they had 2, that's typically the reason why. Next slide. So how does this whole concept of a chest tube work? So there's 3 chambers basically, and you can see in that schematic, all the way to the right is your collection chamber, in the middle is your water seal chamber, and all the way to the left is your suction control chamber. So if you see where it says chest tube on that schematic near the lung, so the chest tube is coming out of the pleural cavity, it's following the length of the tubing into the Pleurovac, into the drainage box. The first thing that's going to happen is if they're draining any fluid or blood, that fluid is going to go in the collection chamber, separate chamber. if they have an air leak, which basically means there's some disruption in the lung parenchyma most commonly. So if they did a lobectomy, they stapled piece of the lung off and send it off to pathology, well, you know, you have a big balloon of all these air sacs. When they staple across, sometimes those little air sacs can leak air into the pleural cavity. And now that air is going through the collection chamber into the water seal. So that's why I put that straw with the bubbles up there. So if somebody's leaking air from their lung into the pleural cavity, it's going to travel out of the chest tube, through the Pleur-evac, through the collection chamber, through the water seal. And I'm going to show you a video of that. So if you see bubbling in the water seal chamber, that means that if you took that chest tube out today and that lung is still leaking air into the pleural cavity, it's going to gradually build and build and build and start to collapse the lung and create a pneumothorax. So you would basically be removing the chest tube prematurely. So you always want to check for evidence of an air leak by having the patient take a few deep breaths, just to get the lungs nice and expanded, and then have them cough. That really helps to evaluate for the presence of an air leak or not in that water seal chamber. And then in the final chamber, you have your suction control. There's two different types of chest tubes. I'll show you that a little bit more in the next slide. So let's go to the next slide. So there's two different types of atrium Pleur-evacs. There's wet suction, which is on the left, and then there's dry suction, which is on the right. So I starred the dry suction because I don't think I've ever seen a wet suction drainage container. It's like an older method of chest tube drainage. So the suction in a wet suction drainage is controlled by the column of water. So where that blue arrow is pointing, I'm trying to show you that that column of water there is up to the 20 centimeter line. So the nurses would literally have to make sure that water is not evaporating out of there. It's always at the 20 centimeter line. If that Pleur-evac gets knocked over, that water column could transfer to the water seal column and it could mess up your readings. And also if you have a air leak, I talked about the bubbling in the water seal chamber, that can get transmitted into the suction column. So it's just like, it's not the ideal system. I just kind of wanted to let you know that it's out there in case somebody says, is this dry suction or wet suction? They probably won't, but just letting you know that's what it is. So the dry suction method, the one on the right, it's all controlled by a built-in regulator. That suction control dial that I have circled in red, that is where you control the suction. The pros are it's quiet, there's no evaporation to worry about. If you knock it over, no big deal, nothing's gonna matter. There's a wider range of suction that you can adjust on the dry suction, -10, -20, -30, -40, whereas the other one only goes up to, it looks like -20. Again, I don't really know for sure because I never really used it, but the manufacturer told me that there's a wider range of options on the other one, so I'm going with it. So as long as there's adequate airflow from the wall suction, this is kind of confusing if you've never seen a chest tube before, but I'll take you through it. So actually, let me show you this real quick. So this is the chest tube, the atrium. So when you go in the room, you're gonna see this little white port here on the top. So just like an NG tube is connected to suction tubing from the wall gauge, the suction tubing should go directly on this little spout here. So pretend this is tubing coming out of the wall from the suction gauge. You literally make sure that it goes right on top of there. So the suction, now, as long as this is connected to the wall suction, I can adjust the suction. Oh, by using this dial right here. See that little lever right there? So right now we're at -20, and I'm gonna move it to -10. So again, I'm just moving this lever right here, which is behind the suction control chamber. Now we're at -30. But the only way this will actually manifest as like -30 is if this is connected to the pressure gauge on the wall. And the way to know that you have adequate pressure coming from the wall is you'll see this little orange balloon. See how it's flat right now? It'll actually pop open into the window where this arrow is. So most videos recommend turning the suction on the wall up until about 80 minimum, and then that will pop your balloon out to know that, okay, now I know I'm at minus 30 suction. If you turn the wall suction on and you want minus 30, but you don't see this balloon inflate to that arrow line, you got to turn the wall suction up more to get to achieve minus 30 suction. So then let's say the surgeon comes by, says, oh, they're doing great. I don't need them on suction anymore. I'm good with water seal. All you do, pull it off of that little knobby here. Pull the suction tubing off. If the suction is on the wall and this tubing is on here, you might really have to yank it off to get the suction tubing off the top of this. So hopefully that was helpful. Okay, next slide. Just going through some of the components of this again. Okay, so let's go back. This is, I wish I had a chest tube. I think there's some videos that will be helpful. Oh, just ignore me. All right. This will already be set up for you, so you don't have to worry about it. But okay, so when I take this out of the packaging, this is the atrium with this little hose type thing. You can take this blue cap off and you have this little connector piece. And now I have my Pleurovac tubing with a blue clamp. This is just, you can take this off. And this will be what connects to the chest tube. So this end goes into this end. Click. So now you can tell it's together well. And then to get them apart, you press this button, pull it apart. Put it in, click. Okay. Excuse me. Okay, so now I have my chest tube. This is like, pretend we're in the operating room. Pretend we're in the operating room. I have my chest tube in. This is what's visible outside the skin. The surgeon is going to take the other end, which looks like a triangle football piece, and put it in to the edge of the chest tube. So let's say the nurse calls you in the middle of the night that the chest tube became disconnected. The patient was moving, and boop, it became disconnected. You would pick up this piece, look for the edge of the chest tube outside the skin, and literally just put them back together. Like that. Sometimes you'll even see people tape around this, but the surgeons I worked with didn't really like that because then you can't visually see that this is a secured connection. So I don't know, everybody's different. You do what you feel comfortable with and what you think is best for the patient, but this is how it will look. You'll see this coming out of this. You won't see any of this. You'll see this coming out of the skin. This is now connected to your drainage box. Okay? All right. Next slide, where were we? Oh, we're still on slide 7. All right, so needleless access port. Do we have that on this one? I don't think we have that on this one. And I don't think we're commonly sending samples from chest tubes, and you know, you're not gonna be asked to do that, so I wouldn't worry about it. Your carrying handle is right here. If you have to take the patient for a walk, take the patient to a procedure, you can carry it right here. This has a little stand on the bottom that kicks out. So often when the only time that I use the stand is if I'm pulling the suction tubing off of here and it's really difficult, that I'm having a hard time getting it off for some reason. I will put my shoes on this stand and use that as leverage to pull off the suction tubing. Other than that, I don't really use it. Tube clamp. Where I worked, sometimes we would give patients a clamping trial. Like if we weren't sure, okay, it looks like the air leak is resolved, but we're not really sure. We would basically slide this clamp onto the Pleurovac tubing. So now it's basically like you have a chest tube in the patient, but the chest tube, you're not really using it. You're basically seeing if the patient can tolerate not having the chest tube function. So we would do this for like, I don't know, every surgeon was different. Again, anywhere from 1 to 4 hours. We'd get a chest x-ray, and if the lungs stayed up, there was no evidence of a reaccumulation of a pneumothorax, then that was confirmation that we knew they were going to be okay and we'd remove the tube. I haven't seen clamping trials done at GBMC, but just in case you come across that, that is why that's there and how that works. Again, something that when you're troubleshooting chest tubes during the day, during the night, make sure that that clamp is not clamped, that it's in this big part. And again, it just slides on that silicone tubing. So I'm sliding it, it's kind of hard, this way. Now it's clamped, sliding it this way, now it's not. Okay, so make sure it's not. Did you like that? Okay, let's see what else. Patient connector, we talked about. Floor stand, we talked about. Air leak monitor. So when the nurse sets up the chest tube, she gets this syringe of water. And the syringe of water, I don't exactly know where it goes. I think it goes up here. It might go in the back somewhere. But anyway, it fills up this water seal chamber. So it makes the water blue. And there's a little blue ball in there that will float on top of the blue water. So if the patient has an air leak, this is where you will see the bubbling within this window. Again, that is where you will know if you have an air leak bubbling in this window. Okay, bellows we talked about. Suction control regulator we talked about. Suction port we talked about. Okay, next slide. I like this schematic because it really shows like visually what an air leak is. Again, I told you that like lung parenchyma, for whatever reason, it's leaking air, most commonly following a wedge or a lobe resection where you're stapling across lung tissue and air is escaping surrounding the staple line. So you can see the tip of the chest tube is in the pleural space to collect that air. I think I already told you that I usually have the patient take a few deep breaths and cough to evaluate. So now pause my video and watch this YouTube link at the 3-minute mark, which explains some of these things in a little greater detail, and then play me back and we'll keep going. Good? Okay. Next slide. So now we're on suction. So again, if we're going to use suction, we got to make sure that we're, oh good, I put pictures of the suction gauges on the wall. Like before I did thoracic surgery and worked in a surgical IMC, I was like, I don't know how to do any of this stuff. I don't know what these suction gauges are, what these tubings are, what these drains are. Like I know nothing. So these are all different types of suction gauges. The one all the way, I'm at the bottom picture. The suction gauge all the way to the left turns on by sliding the lever along top. I think you can see right now it's in the off position. So if you turn it to the left, it looks like it's going to be on regular, and the other way, I think, I don't know, intermittent, I don't know what the heck that says. But anyway, that's how you would turn it on. And then the black dial on the bottom, you push it in and turn it to get it to low, medium, or high. Again, we're aiming for about 80 minimum, or whatever it takes to get the bellows visible in this window. So, I mean, if you have any questions with these suction gauge monitors, the nurses are such good resources to be like, hey, how do you hook up the suction tubing? Can you just like show me? I've never done this before. I've done that countless of times. They are so, so great with helping with this. Okay, so as long as we have our suction tubing on the gauge is on, it's connected to this little lip. We have our suction set where we want it, -30, though most commonly it's -20. So let's go ahead and switch that, -20. I'm using this little dial thing. Okay, we're making sure that our bellows is at the delta, at this little arrow right here, to make sure that we know confidently that we're at -20. If we don't see it, we're increasing the wall suction. This is a Pearl from, I wouldn't even worry about it. It's just like if somebody has a really, really big air leak that's not getting better, sometimes turning up the suction is the opposite thing to do because you're stenting open that hole. And sometimes we even convert them to water seal. Again, I don't think we're going to, I think I might just delete that out of here because I don't want to confuse anyone. Don't worry about it. Okay, titling. So this is when the water level in the water seal chamber fluctuates with respiration due to changes in the pleural space. So if you're at the bedside and you have your water in your water seal chamber and you're watching someone breathe, you're going to see this, it's going to go up in this column and down, up and down, up. It might even go like all the way up here and down and up and down. And that's basically just reassuring you that it's in the right spot. It's vacillating with changes in pressure during inspiration and expiration. However, sometimes you don't always see that. And sometimes that is because you have pleural-pleural opposition and it's like smushed and you're not able to see that. And sometimes, I would say oftentimes, when you go to take the chest tube out, you can see these pictures that I have put in there where the eyelets are, it'll be all clogged with fibrinous tissue, blood clot. So it's not able to tidal because it's not, air isn't flowing through. And 9 times out of 10, if that is the case and the lung is remaining up and the patient's not short of breath, there's no more problem like intrathoracically, so it's okay. Obviously, if the patient, your tube isn't titling, patient's getting more short of breath, the pneumothorax is getting bigger, then you have to be concerned. I think there was like one patient ever that happened where we actually had to get something called a Fogarty catheter. It was like some type of vascular catheter, and we had to like, the surgeon had to, at the bedside, disconnect the whole circuit and like rotor-rooter of the chest tube. It was crazy. So that doesn't commonly happen. But I just wanted to tell you, if you don't see your tube titling, don't freak out. You don't need a new tube. It's not an emergency. As long as the patient is not having worsening shortness of breath, satting fine on room air, you have good breath sounds, it's probably fine. Again, watch that YouTube video. It'll explain it more. When you're done, come back to me. All right, now we're on slide 11. So these are 2 different types of mobile devices. So you can see this thing is huge, but like if I have had a pneumothorax, like a small pneumothorax, a small air leak for like a week, and I'm like, I need to go home, I can't do this anymore. Sometimes the surgeons will say, okay, just switch them over to a mini atrium or put them on a Heimlich valve. So on the left is a Heimlich valve. Again, I haven't seen it used here. More commonly, or all the time, we're using mini atrium. So you can research Heimlich valves on your own if you're interested in them. We do them at University of Maryland, but kind of waste of time right now. So mini atrium, if you are going to be switching somebody over to that, you're going to unclick this little button here and disconnect. So now let's see. I've disconnected. I have my chest tube. Oh wait, I don't even care, it doesn't matter. Let me think about this a second. Oh, I guess, oh. Okay, I got it, guys. All right, chest tube is in. Fluorovac tubing here. We have disconnected. So you can see on that mobile device, there's that piece that's going to click in, just like we clicked in on our chest tube. This is just going to be in mini size, and we're just going to click in, but on the mini instead of the big one. That was like, I made that a lot more difficult for myself. Yes, I did. Okay, so that's it. And this is a closed system, so once you unclick and you click into the other, you're good to go. So that's it. It's really simple. And then there's nothing further that needs to be done. You can't really evaluate for an air leak as easily in something like this. I think I had to Google how to do it last time I had one because I was nervous that we might have let air in. I don't quite remember the whole protocol for it. So again, if you're in that situation, YouTube, Google, the Getinge website is super awesome. Getinge, the manufacturer of all these atriums. You can almost always find your answer to these questions if you need it. Okay, and finally, removing chest tubes. I feel like Dr. Sullivan will do that by herself most commonly now, but if you need to or asked to, this is how you do it. Typically, you want to make sure that the output from the chest tube is less than 200 cc's in 24 hours, that there's no air leak in your air leak chamber with deep breathing and with coughing, and that on the most recent chest x-ray, there's no pneumothorax. I typically have the patient lay flat. I take the dressing down. The chest tube, let me put this down. The chest tube will be sutured in place here against the skin. So you're going to need your suture removal kit and cut the suture with scissors. And then I have my dressing ready to go. Tape and then 4x4s on top of the tape. So my chest tube is cut. I have the patient lying flat. I sandwich the dressing against the skin, and then I have them take a deep breath in, blow it out, and I pull. and my dressing is already in place. Some people have people hum, hold your breath, blow out. It doesn't matter, just as long as it's some type of Valsalva or breath holding or exhaling maneuver, and you're keeping a dressing in place as you're withdrawing. A lot of people like to use Xeroform or Vaseline gauze in addition to the 4x4s and the tape. My team didn't like that because they said once the patient goes home, oftentimes they like keep the dressing in place for longer than they were instructed to, and then that wetness, moisture from the Vaseline or Xeroform starts to macerate their skin, and that hole doesn't seal very well. So they were proponents of just dry gauze and tape, so that's what I do. But again, you do whatever you feel comfortable with. If you want to use Xeroform or Vaseline gauze, you certainly can. Just instruct the patient that after 48 hours to take it off. And then also instruct them that they still could drain a little bit of like Kool-Aid looking or serous looking fluid. And if they do, that's normal. And to just keep putting a dressing in place. And sometimes it's completely dry and no further dressings are needed. Once you take the tube and all of this and this out of the patient, I put the kickstand back under the Plurivac, and I put this entire thing, all of it, in a red bag, and then put it in a red garbage can. Again, one last YouTube video. I love YouTube videos because if you've never done it, it really helps to see it. So this guy, I think, has him breath hold, and he uses Vaseline gauze and tape, but just the mechanism, I think, is helpful. And that's it, guys. I hope this was helpful. Sorry I couldn't do it in person. But yeah, if you have any questions, I'm going to have this sitting in the lead office. Feel free to grab me, grab it, so you can do some hands-on learning, or if you just like something didn't quite click, you can email me, reach out to me, and we can like go over this together. Okay, thanks. Bye.